Thank you, Lila, and thank you, Doctor's Data, for having me. This has been a lecture that I've wanted to give for Doctor's Data for a while now. As Lylan said, I teach other doctors and I do a mentorship course where, I get a lot of one-on-one with doctors who need to integrate the knowledge. And one of the most common questions I get is what to do with stool tests. We all know how foundational it is and how much information it gives us in clinical practice, but what to do with the results? And Doctor's Data has a large menu of GI tests, which is wonderful, but it also, which one do you do? And which one, how are they different and which one is needed for each case? So that's what I want to do, cover today and help doctors and practitioners just get a sense of how to use these in clinical practice, what to do with the information, and really which ones to order. So that's the first learning objective, is just navigating the Doctor's Data GI test menu, which is robust, and that's great. And then we'll dive into how to interpret the microbiome and microbiology data, what to do with all of this, what is the dysbiosis index and diversity score, and what isn't, what it isn't. We'll apply some clinical relevance principles. So understand when a finding is actually clinically actionable, or is it just something to follow, or what is really causing that finding? So that's really important, because a lot of doctors know how to interpret the test, but they still don't know whether it should be treated or not. So that's a very important and common question. Stool chemistries is one of the unique things that Doctor's Data offers that most tests don't. Most GI tests don't. So it's gives you a lot of information about how the GI test or how the GI system is functioning in that patient. I'll also throw in a couple of snippets about C. diff, because we're seeing a lot more C. diff, at least I am in my practice, and a lot of them are just carriers, and when to distinguish whether it's should be treated or followed, and also you might get a call from your state health department, because these things, Doctor's Data in many states has to report that. So you have to be able to know whether to treat, whether to refer. So I wanted to throw that in there. And then finally, we're going to do a case study, and we'll apply a lot, not just the GI test, but how does a GI test actually fit into a full clinical evaluation for a patient, which is really important, because we're not just a walking, gastrointestinal system. So why does comprehensive GI tests matter in the first place? Well, we all know that the gut is central. 70-80% of the immune system resides in the gut-associated lymphoid tissue. 95% of body serotonin is produced in the GI tract, much of which does cross the blood-brain barrier, so it does affect the neurology system. Neurotransmitters. Gut dysbiosis and leaky gut is linked to autoimmune, neurological, metabolic disease. This is nothing new. Intestinal permeability drives systemic inflammation. The microbiome directly influences our own epigenetic expression and inflammatory expression. Things like short-chain fatty acids and lipopolysaccharides regulate the HPA axis, barrier integrity, and GI pathology often precedes and drives systemic presentation. So evaluating the GI even before disease presents becomes a really critical point of prevention as well. So don't wait to do a GI test just when someone is symptomatic. So the GI 360 specifically, which we'll go into first, 45 plus target analytes, which we'll talk about in the microbiome profile, 14 different PCR pathogen targets, 1,600 plus species, and they build it every day, are identifiable in their library via the culture and MALDI-TOF, and 31 plus parasites screened via the 3-day microscopy, which is what I always, or parasitology, which is what I always recommend, is doing a 3-day collection. So just briefly, my version of the gut microbiome human health matrix, why the gut microbiome is central to human health. We have all of these endpoints: the gut neuroendocrine system, The gut affects neurotransmitter metabolism, the hypothalamus, pituitary, the what we call the endobolome, which is how it translates, how it metabolizes, how it enters recirculation of our hormones, and even chronic pain is regulated through the gut and hypothalamus, pituitary, and brain axis. So just a little snippet of the gut neuroendocrine connection. The gut affects neurotransmitter metabolism, HPA, adrenal dysfunction, and chronic stress response. This chronic pain and gliopathy, activation of glial cells and neuroglial cells because of the leaky gut, because of the metabolome, can cause and drive a lot of chronic pain. We call it gliopathy, and it is truly a enteropathy, a gut-driven system. The glutamate signaling, glutamate accumulation is a key factor in brain fatigue, and glutamate is made in the gut when there's a lot of dysbiosis. So again, one of just a little clinical pearl. NAC is one of my favorite. N-acetylcysteine attenuates neuropathic pain by suppressing the matrix metalloproteinases 9 and 2. NAC induces neuroplasticity versus glutamate modulation, normalizes spinal cord oxidative stress, and it's one of my favorite in healing the leaky gut. So I'm going to kind of smatter some of these clinical pearls through this lecture today. So it's not just learning about the test, it's learning about some clinical pearls and things that I've found in 20 years of practice to be indispensable. And for dosing and all that kind of stuff, it's very individual. So that's one of the questions I get a lot. Well, how much do you use to heal gliopathies and glutamate signaling and inflammation? Typically, it's 1,500 to 2,000 milligrams twice a day. So, NAC is also a gut, a microbiome disrupting, a biofilm disrupting agent. So we often use that in dysbiosis protocols as well. So we have the gut mitochondria axis, which is very underappreciated in a lot of practices. The gut directly affects mitochondrial uncoupling and mitochondriopathies. It's part of the metabolome, so things like lipopolysaccharides and short-chain fatty acids regulate mitochondrial function. And of course, gut dysbiosis directly contributes to mitochondrial oxidative stress and either reduces glutathione production or it takes up all of the glutathione in the gut. So essential mitochondrial support agents, CoQ10 is number one, quercetin, all of these things are needed if there is a gut mitochondrial dysbiosis axis disruption. One of the things here I want to point out is D-ribose. Ribose is one of my favorite and also underappreciated in terms of healing the leaky gut because the enterocytes take up a lot of ribose. And ribose heals leaky gut. Lots of studies on ribose and healing leaky gut and skin lesions. And also ribose is a necessary substrate in the mitochondrial pathway. So just another little clinical pearl there. And as Lylan said, if you have questions, we'll try to get to as many of them at the end as possible. So stay tuned because we'll do a Q&A session. And those often are very, very productive and very interesting. So we have the gut structural system that's also underappreciated. The gut joint axis, the gut drives osteoarthritis as well as rheumatoid and psoriatic and autoimmune arthritis. So very important to know that connection. And just for those of you who have musculoskeletal patients in your practice, it's not just about managing pain. It's about what is the source of pain and destruction in the joint. And the gut joint axis is one of the most important. The mitochondria gut joint axis as well, because the mitochondria is in the chondrocytes. And so if there's a mitochondrial dysfunction as well as an osteoarthritis, then that's a setup for a lot of chronic pain. And the joint gut axis in irritable bowel disease is very well known. Key support agents there, sulforaphane is one of my favorite, EGCG, lipoic acid, and omega-3s, and again, CoQ10. These regulate the gut joint axis very well. In addition to glucosamine, chondroitin, curcumin, those kinds of things as well. But these are some of my favorites in clinical pearls. The gut immune system, we all know very well. inflammasome control, cardiovascular effects, the autoimmune triad, the three things that all autoimmune have in common. It's genetic predisposition, leaky gut, and dysbiosis. And then the third thing is some kind of environmental trigger, or what's known as the straw that breaks the camel's back. Could be stress, could be an infection, could be toxic exposure. But those three things exist in all autoimmune diseases. And if you want to know more about any of these are all the things that I cover in the nutritional pathology certification course, which I'll get to at the end. So the gut-lung axis is really important. And one of my favorite drivers of this gut-immune connection is short-chain fatty acids. Short-chain fatty acids modulate immune cell function. Butyrate regulates T cell differentiation. Propionate influences dendritic cell maturation. Acetate provides energy for colonocytes and immune cells. And melatonin is one of my favorite in this gut-immune connection. A lot of people don't understand how melatonin affects the leaky gut. It's one of my favorite for healing the leaky gut, and it's one of my favorite for autoimmune and inflammatory conditions as well. So the gut genome and the gut epigenome, our gut, the dysbiosis and the metabolome, endobolome directly affects not just our epigenetics, but truly we incorporate bacterial genes into our own genome, and that's a big part of cell regulation and diversity and how the system adapts to the environment. But methylation and gene function, of course, we can't methylate very well. No matter what your MTHFR status is, we can't methylate well unless the gut is healthy, because we can't absorb the nutrients we need. And a dysbiosis and leaky gut takes up a lot of methyl nutrients in order to survive. And we've got microbiota disrupting chemicals, things like plastics and chlorine in the water. They drive more dysbiosis and leaky gut. So interesting about the leaky gut and methylation. So you can even reverse some SNPs. You can heal some SNPs. There's a lot of evidence that when you have leaky gut and dysbiosis and chronic inflammation, you actually develop more SNPs throughout your lifetime. So some of the studies I've seen, 15 to 30 SNPs you can develop. So your genes can actually permanently change based on the leaky gut and dysbiosis status, but they can also reverse some of them. So we were all taught that SNPs and our genetics are static, and they are not. They are not static. We can actually change them, and the gut gene axis is one of the most important. So and of course it drives aging as well. Gut fertility, another axes that's very misunderstood and underappreciated. I do a lot of fertility and fetal development and preconception in my practice, and most people should be doing that, in my opinion, because fertility rates continue to rise. I'm going to be giving a talk with Biotics research next week, March 4th, on testosterone and fertility. So if you want to tune in, you can go to Biotics website, or you can go to my website, drbrandonlundell.com, and sign up there. But fertility and fetal development is very much driven by the gut. And I've treated hundreds of parents and parents to be in couples throughout the years, and the key deciding factor, whether I know someone is going, a couple is going to actually not just get pregnant, but have a very successful pregnancy and their child, higher development IQ and EQ, it is whether or not they can heal the leaky gut preconception. That is my number one indicator of both fertility and successful conception. So very, very important. One of the things here that I don't have here, but phosphatidylcholine is one of the most important, both in healing leaky gut and fetal development, fetal epigenetics. So phosphatidylcholine is one of my favorite as a clinical pearl there. And why we always treat both the male and female in any fertility case. It's a 2-for-1 in my practice, because I won't treat just one or the other. You've got this partner microbiota exchange happening all the time, not just during intercourse, but also saliva and what you're sharing and the environment. So Very much, very important to do both. So, and then finally, the gut detoxification and elimination. You're not just talking about the gut's influence on phase 1 and 2, but also phase 3 and the efflux, portals, pumps there in the gut. So, raising glutathione naturally is probably one of the most important clinical concepts to master and to understand. I spend a lot of time on this in my courses. It's not just throwing glutathione. Taking glutathione, whether sublingual or oral or parenteral, it's actually one of the greatest wastes of money in functional medicine that I see out there. And I can go, I go more into that. Not that it doesn't help, but it is so expensive. And, you're only absorbing maybe 5 to 10% of glutathione. Plus, there are no glutathione transporters that allow glutathione into the cell. So when you take glutathione by itself, what you are doing is you're helping the extracellular environment, there's no doubt, but glutathione breaks down in a matter of minutes in the body, and it's very expensive. So what I do to raise glutathione naturally, where you want it the most, 80%, 90% of our glutathione exists where? Extracellularly or intracellularly? Intracellularly. And so taking glutathione does really not help intracellular glutathione levels raise that much. You've got to build the mechanisms for your body to make its own glutathione. So we use lipoic acid, grapeseed extract, N-acetylcysteine, SAMe if you need to for a while, glutamine, because glutathione is, after all, N-acetylcysteine, or it's cysteine, glutamine, and glycine. So making sure that there's enough substrate there. Silymarin, cordyceps, curcumin, sulforaphane, green tea extract, any or all of those help support intracellular glutathione. So I actually don't use extracellular glutathione that often in my practice. Again, it's very expensive. I'd rather use my patients' dollars to do these things, N-acetylcysteine and lipoic acid. Glutathione is helpful for short term if you're traveling or if you're getting exposed to things, to toxins, then by all means take extracellular glutathione because it's very helpful chelating some of these toxins even before they get into the cell. But I'm going to focus more on the intracellular glutathione. And then you also have all of these, mixed, it's not just bidirectional, it's multidirectional. All of these are talking to each other all the time. So it's very important to be able to assess the metabolome, the GI system, and to support this in your patients. And it's so much more than just giving them glutamine and zinc and some probiotics and some prebiotics and hoping for the best. That's been shown to be very, very short-lived and also very expensive for the patient. So a quick understanding of the metabolome: it's a repertoire of small biomolecules present in cells, tissues, and body fluids, and its composition is at the core of health in all individuals. So this new metabolomic platforms, this is a lot of what we're looking at in the GI 360. So we're talking about glycolysis-related molecules, G6PD, tricarboxylic acid, acetyl-CoA, all of the amino acids. So we do look at organic acids as well, and lipopolysaccharides and short-chain fatty acids, all of these bacterial-derived metabolites and xenobiotics are all part of the metabolome. Short-chain fatty acids is one of my favorite because not only can you help your patients, help your own microbiome produce the short-chain fatty acids, but you can give short-chain fatty acids usually for a few months to help heal leaky gut and to help balance the autoimmune system, to help balance inflammatory regulation, neurotransmitter regulation. So short-chain fatty acids are produced. Butyrate is one of the most important. It's the most abundant. Acetate propionate. They cross the blood-brain barrier. They cross the intestinal barrier, whether it's intact or not. And we have many receptors for short-chain fatty acids that regulate the inflammatory response and regulate the mitochondria. So I do use butyrate quite a bit in my practice, and I'll show you in the case study when and how. This is a study that I've used the last couple of years. Does an altered microbiota and leaky gut actually affect COVID-19 severity? Well, of course, we all know that now, but we have many, many studies that is the greatest predictor of not just COVID and immune responses, but your overall comorbidity and comortality status. So, and Clostridia species, is a big one. And I'll tell you a story about that and how those converge to be very deadly. As I said, melatonin, besides playing an important role in various functions in the body, including sleep and circadian rhythm, but it also shows immunoregulatory, free radical scavenger, and antioxidant function. So one of my favorite pleiotropic molecules is melatonin. And you actually don't need as much as a lot of people. Some people are taking 5, 10, 20 milligrams. The studies show you really don't need that much. Over 3 milligrams, you're not getting that much more benefit. Okay. And so then you're diminishing returns. And I'm always trying to make sure that my patients are, look, functional medicine is expensive, right? We want to make sure that we are giving our patients the best value for their treatment plan. So sometimes there's reasons to do 5, 10, even 20 milligrams, but at that point, it's just a very expensive antioxidant, and you can do more. You can do better with high doses of vitamin C and things like that. And then if you are doing things like vitamin C and grapeseed extract, then you actually don't need as much melatonin. Because it's going to be preserved as an antioxidant. And that's one of the major reasons why we see low melatonin. Doctor's Data has a wonderful melatonin test, saliva and urine, and it's one of the biggest reasons why we see low melatonin is not that the production is low, it's that it gets used up in an oxidative environment very quickly. So remember that. It's not just about lack of production, which usually methylation is a part of. So that could be a big part of low melatonin is supporting the methylation pathway, but it's often just that it's used as an antioxidant. It's used up very quickly. So build your patient's antioxidant levels. So through your vitamin D, vitamin C, vitamin E, and acetylcysteine, and that spares melatonin in the nervous system and throughout the body. Melatonin is also known as a clock gene regulator. So without melatonin, we don't trigger our repair mechanisms, things like autophagy and all of those things, mitophagy, at night if we don't have enough melatonin. So it's not just a sleep regulator. I tell patients it's not about sleep because I'll put someone on melatonin and they'll be like, I sleep fine. Why do I need to take melatonin? Or they'll take it for a few weeks and they're like, I'm sleeping fine now. I don't need to take it anymore. No, I'm very clear to let them know we're using melatonin as a nutraceutical. We're using it in super physiological amounts to regulate mitochondria, to regulate the immune system, to regulate the clock genes and repair. So it's one of my favorites. Okay, enough with some of those clinical pearls, and hope those are helpful. I always like to throw those in, but let's get down and dirty with the GI test menu. What tests do we really want to run? We all now know how important the GI system is, and if you're really not assessing it, you're missing a lot, and your patients are missing a valuable piece. A lot of practitioners only do GI testing when there's GI symptoms, and that is too bad. I want everyone after today to think about running GI tests in almost every one of their patients. As I said, not only does it treat a multitude of symptoms extraintestinally, but it is at the core of prevention and optimal functioning, right? Let's not forget that the term functional medicine means that our job as practitioners is to make sure every cell, every tissue, every organ, every gland, every system is functioning optimally, and dysfunction precedes disease. So the GI 360, we've got the microbiome abundance and diversity and GI pathogens. We'll get into that. It's got the bacterial susceptibility and stool chemistries. You can do add-ons like H. pylori, stool antigen. You can do zonulin. You can do a comprehensive Clostridium culture. Usually, if we see a C. diff toxin, then that should trigger the C. diff culture. Then you have macroscopic, look, and you have worms ID, parasitology. How that differs from the comprehensive stool analysis plus parasitology is that you don't get the microbiome abundance and diversity, but you get all of these other things. Okay, so sometimes you don't need the microbiome abundance and diversity, and I'll tell you why, down the road, but in a few minutes. A lot of times the GI 360 becomes your initial assessment, but these other tests become your follow-up assessments. The comprehensive stool analysis gives you the bacteriology and yeast. It includes everything except the microbiome and the PCR GI pathogens. Okay, but you still get the bacteriology and yeast culture. This is one of my most common follow-ups because a lot of times parasitology is negative, so you don't need to pay. Your patient doesn't need to pay for another parasitology if it's negative the first time, unless you get a clinical indicator, okay? And whether, maybe if they develop another symptom, diarrhea or, severe constipation or pain. And then you can do the microbiology only if that's the only thing that was off in one of these tests and you want to follow up. But it's very important to follow up. This is a common mistake that a lot of practitioners make is either they think that because the patient is asymptomatic that they did their job, or they don't want to ask the patient to pay more money or something. There's many different reasons, but follow-up is often missed in most of the doctors that I get when they start to come and train with me. So follow-up is very, very important. Not that you have to keep testing until it's perfect by any means, but following up when you have a major dysbiosis or pathogen is really important. So this is just another way of looking at this. Doctor's Data has a really good PDF that you can download online, and it's their whole GI testing PDF, and it goes into a lot of these things. So this is just what you get and what you don't get. So my progressive testing strategy is always start with a GI 360, even if they've done a GI map or they've done other tests. The GI 360 is the most comprehensive test on the market. There's no doubt about it. And so you want to get all of the components in the GI 360, even if they've done another test from another company. Also, there are differences in methodology that, in my opinion, and many other opinions out there, the Doctor's Data GI 360 uses the more gold standard technology like the MALDI-TOF culture. There's really no other company out there that's doing the gold standard like that. So a lot of times the first follow-up will either be the CSA plus parasitology if there is something off in the parasitology, or just the CSA. And oftentimes then the microbiology, we only need to do the microbiology, and we'll show that if there's bacterial yeast imbalance specifically. It's the most cost effective, and it confirms dysbiotic organisms, and it gives you a little information about the commensal bacteria as well. It gives you just a quick overview of the major phyla, which I'll show you. So that's how we kind of reassess. It just depends on what's happening. We almost never, like I said, I almost never do the GI 360 again unless there's a new symptom that warrants looking at the microbiology or looking at the commensal microbiome. Okay, so here's a picture of the first page of the report of the GI 360. This is a big source of confusion, so let me try to clear this up. This hexagon-looking thing is your 6 major phyla, okay? You're supposed to look like this spider web. You're supposed to look like the patient is supposed to, the white shaded area is supposed to look like this hexagon. So you can see that this sample patient has a lot of Firmicutes and overgrowth Firmicutes, but an undergrowth in some of these other areas. Now, this dysbiosis index is only looking at your commensal microbiome. It's not looking at the microbiology profile. And this is a really important point. So it's important. The dysbiosis index gives you an idea of what the commensal bacteria looks like. Is the expected bacteria in your gut out of balance or not? And you can look at the diversity score as well. So it's based on Shannon's diversity index and many studies that look at diversity across populations. So it's great to evaluate your commensal bacteria, but it does not take into account. There's many patients where the dysbiosis index is a 1 and they have severe dysbiosis because when we look at the microbiology, we'll see that the culture actually grew more pathogenic bacteria. This is only looking at the commensal bacteria. So I hope that's clear, and it should be clear to your patient. You should make it clear to your patient that, okay, this dysbiosis index is only looking at what should be there. It's not really looking at what shouldn't be there. Okay. So then you've got the GI health markers down here. What was positive, what was negative, key findings. So you can see this patient, not only does it have an altered commensal microbiome in this hexagon, but it does have Citrobacter and Enterobacter and Klebsiella, which are known dysbionts or pathobionts. Okay. Now, the next few pages of this report, which we'll get to, I'll show you what that looks like again. The next few pages is only going for looking at the commensal bacteria, which is important when choosing a probiotic, and it's important in choosing some dysbiotic agents if you're going to treat dysbiosis with antimicrobials, natural antimicrobials. So we have the microbiome abundance and diversity here. So like I said, it does not include the dysbiosis bacteria, yeast, parasites, or viruses, which doesn't discount the importance of this. Okay, it doesn't discount the importance of the dysbiosis index, but it's just looking at, but importantly, looking at the commensal microbiome. So only when a 3+ or 4+ growth of major dysbiotic bacteria is present will it potentially affect the microbiome score. Okay, so it doesn't tell you whether you should treat it or not. So here's the 6 major phyla. I don't need to go into these. You can read about these. It's important to know because it can affect the symptoms and also it can affect the prediction of diseases. So really important to know, but that's beyond the scope of this lecture, which is really just looking at what are the differences of the tests and how do we choose which test to run and what to do with the information. So PCR here, the multiplex parasitology, PCR does not differentiate viable from non-viable organisms. Do not repeat sooner than 21 days after treatment to avoid false positives from lingering DNA. What I mean by that is just because there's a positive result on the PCR, it doesn't mean that it's actually pathogenic. You have to couple the PCR result with clinical symptomatology, and I'll get to that when we're looking at the C. diff and things like that. So it includes 7 to 8 pathogenic bacteria plus 3 viruses. The 3-day microscopy or 3-day parasitology, 31 plus parasites screened, and we'll talk about that. It also includes the microscopy, which is invaluable. Doctors Data is one of the only companies that does an actual microscopy. What does that mean? It means we're getting eyes on it. We're actually, someone who's trained is actually looking at it and saying, all right, maybe the yeast didn't survive the PCR, maybe it didn't survive transit, maybe for some reason it didn't grow, which there's many reasons why, which is why you have to have multiple targets, multiple aspects of evaluating a stool. And most companies only use 1 or 2, whereas Doctors Data uses 4. And this microscopy is really, really important. So someone's looking at it. Do I see yeast? Do I see red blood cells? Do I see white blood cells? Do we see muscle fibers, vegetable fibers? Do we see mucus? Whether or not it showed up. Okay. So I almost always prefer the 3 specimen collection. It increases parasitology sensitivity from about 85% to about 96 to 98%. So positive PCR without symptoms may indicate biofilm disruption or paraintestinal colonization. So you just have to really take the information and apply it clinically. With blastocystis or endolemax, evaluate the full clinical picture before initiating treatment. I have seen many patients come to me after, seeing other practitioners, and they have been harmed not just financially, but also gastrointestinally because they were told they had a parasite. They were put on a very aggressive treatment plan, and they were never the same. They were worse. Never the same is good if they're better. Never the same is not good if they're worse after treatment. And I've had dozens and dozens of patients over the years where practitioners who don't understand how to interpret these results, or maybe they don't even do a stool test and they just say, "Oh, you've got a parasite. I'm energetically picking up on a parasite, and here's these aggressive tests." Please test, don't guess. All right, that's one of the big. I have a couple sayings that define my teaching style. One is a good doctor knows what to do, but a great doctor knows why. I mean, I can teach you what to do, but if you know why something works, why something is there, then you can truly think like a doctor. And the other one is test, don't guess. There's no place for guessing in functional medicine. The microbiology is also one of my favorite aspects of the GI 360 and the comprehensive stool analysis. You get the expected bacteria, imbalanced bacteria, and dysbiotic bacteria, and I'll get into that. Doctor's data uses a threshold of 3 plus or 4 plus growth, meaning Klebsiella, if it's only a 1 or 2 plus, might be in the imbalanced bacteria, but if it's 3 or 4 plus, it gets into the dysbiotic bacteria. So now, there's some evidence to that and why they do that, but it's also you have to, just because it's in the imbalanced bacteria doesn't mean that you don't treat it. Vice versa, if it is in the imbalanced bacteria, doesn't mean you should treat it. You have to look at the clinical picture. And then there's a few pathogenic bacteria that are just positive or negative. If it's there, it's pathogenic, whether it's a 1 plus, 2 plus, or 3 plus growth. And this is what that looks like. You get your pathogenic bacteria. If it's there, it triggers a dysbiotic score. And then you get your imbalanced bacteria. What grows? What's actually growing on a Petri dish? Different than PCR technology, which is looking at the DNA signature and looking at how that shows up in the machines. But the dysbiotic bacteria here, if it's a 3 plus or a 4 plus, it'll be put here. Sometimes they combine them. And then you've got your yeast as well down here. So very important to evaluate this. And this is one of the things that stands out with the GI 360 that other tests do not do. The tests like the GI map, most of that is just PCR technology. And while PCR technology is wonderful, it should never be used as the gold standard or as a single point of evaluation. And then one of my favorite aspects of the GI 360 and other doctors' data tests is that they do a bacterial and yeast susceptibility testing. So if it's susceptible and it's in the green, it means it's likely to respond to standard dosing. If it's intermediate, it may respond, but you'll probably have to use higher doses. And then if it's resistant, it's probably not worth using. And this is tested on each patient's pure isolates, not just wall charts, meaning it's not just put up as what we see to be the most common. A lot of labs use a wall chart, meaning, well, this is what we see with 80% of these samples, and so here you go. Good luck. But that doesn't mean everyone fits in to that wall chart. So the natural agents tested by doctors' data: caprylic acid, uva ursi, olive leaf, oregano, golden seal, and 2 types of silver, ionic and colloidal. So doesn't mean that other agents don't work, like grapeseed extract. They used to use grapeseed extract, but they decided not to because I believe it was just hard to find a good source of standardized grapeseed extract that they could rely on to do these testing. But this gives you a good suite of natural agents that you can use. Susceptibility testing requires cultured isolates, which they do. PCR alone cannot provide this, which is why other tests don't provide this. And and it really is invaluable at knowing what natural and pharmaceutical agents are likely to work. Colloidal silver dosing. 60 mils, a quarter of a cup twice daily, which is what I use for systemic infections. So you do have to use large amounts, in my opinion, and in my research. So taking, a teaspoon or a tablespoon of colloidal silver, that might be helpful as a preventative, but we use in our dysbiosis protocols about a quarter cup twice a day. I do have dysbiosis protocols. If you are interested in a dysbiosis protocol, please go onto my website and just go through contact us and say you'd like, let us know that you'd like a dysbiosis protocol. And I'll give you the exact brands and the exact names and the exact amounts that we use. Now, I'll give you a template. Doesn't mean I use all of those on every patient. So my dysbiosis protocol includes caprylic, uva ursi, olive leaf. Doesn't mean I use those on every one. I will individualize that, but I can give you standard doses and what we use in terms of a staggered or time differentiated dysbiosis protocol where we do 10 or 14 days on just the antimicrobials and then 4 to 7 days on just the probiotics, and we often repeat that for 2 to 3 months. And then we do a washout period for a month, and then we retest. So that's if you're interested in all of that, I can give you those specifics if you email me through my website. But you got to go through my website only. So here is a culture and sensitivity for the yeast. If it's high sensitivity, it means that the agent is likely to inhibit the growth. If it's resistant, it's not likely to work. So, okay. Here's another one for Klebsiella or for a dysbiotic bacteria. Low inhibition means you don't want to use it. Medium inhibition means that it might work at high doses. High inhibition means it works at standard dosing. Now, stool chemistry. One of my favorite aspects of GI testing is this stool chemistry. It's looking at how your gastrointestinal system is actually functioning, which is really what determines the microbiome in the first place, right? So you can't change the microbiome without balancing the stool chemistries. I'll say that again. You can't change permanently the microbiome without changing the stool chemistries. And how do we change the stool chemistries? Well, we restore proper functioning, proper timing, and the proper symphony, if you will, of, chewing and saliva and hydrochloric acid and ghrelin and somatomedin and cholecystokinin and pancreatic elastase. So this stool chemistry gives you an idea of where the imbalance is that's driving SIBO or driving, dysbiosis in the first place. So the pancreatic elastase is one of my favorite because it's actually developed by the Mayo Clinic first, and it's a gold standard for looking at pancreatic exocrine function, not insulin endocrine function, but whether it's actually secreting enough trypsin, chymotrypsin, lipases, and amylases, and bicarbonates. So if the pancreas isn't functioning properly, you're likely going to have dysbiosis. You're setting up an imbalanced, too acidic of an environment where gram-negative bacteria can grow. So without enough pancreatic function. Vice versa, if you're not having enough hydrochloric acid, then you're likely to get undigested proteins in your stool, and the pH might be too elevated, which is also going to cause more dysbiosis. So if you get fat stains, now they could be on a very high fat diet. So ask them if they are. That can, even if they're functioning well, their gallbladder is functioning well, it might be that they are just on a very, very high fat diet. But if they're on a normal fat diet, 20-30% of their caloric intake, and they're still having fat stains, then that often means that there is a gallbladder dysfunction and they're not secreting enough cholecystokinin and bile. So there might be a bile duct issue. There might be, a liver and biliary tree issue. If they have high bilirubin in the blood, then it's likely a biliary tree inflammation. And so you want to do a lot of N-acetylcysteine and SAMe and taurine and ginger and curcumin to thin the bile tree out. If they have a lot of carbohydrates, then they're not secreting some of the amylases, some of the trypsin and chymotrypsin. So back to the pancreas, or they have a very, very high carbohydrate diet and very rapid transit. Other microscopic markers of digestive health, muscle fibers, vegetable fibers, yeast. If you see a lot of those, it means that, you know, the yeast, if they see that under the microscope, but it doesn't grow, it could be that they're just eating a lot of yeast in the food. So make sure that you differentiate yeast that needs to be treated versus yeast that is transitory. So here's your stool chemistry. Here's your the elastase. My cutoff in the literature. So 200 is what the Mayo Clinic uses, and therefore doctor's data. But this is a disease range. It's not an optimal range. This is another misconception about ranges because doctor's data is a very functional medicine oriented. It's assumed that they use functional ranges, and the FDA doesn't allow that. The FDA requires established population-based ranges. So it's still up to the practitioner to know what might be more clinically relevant. So, in my opinion, in looking at my population and empiric evidence, and in some of the studies that I've read, I use a cutoff more around 300 for the elastase, 350. So if it's lower than 300 or 350, that's an indicator that it might be struggling still. Not to the point of disease or what can be called a true pathology, but they still might not be producing enough for optimal digestion. So at that point, I still might consider using a trypsin, chymotrypsin, pancreatic-based enzyme at that point. If fat stain's elevated, I might use some bile acid thinning agents like I mentioned before, but I also might just use bile salts as well. So very important. Now, lactoferrin, there's many doctor's data has a couple of really good videos that go into the difference of one of these. What I'll tell you is that if lactoferrin or calprotectin is high, you're likely looking at irritable bowel, some irritable bowel disease. If it's just lysozyme, if it's just one of them, calprotectin is probably the most serious out of all of these. If calprotectin is elevated, then that's almost pathognomonic for an irritable bowel disease. Okay, if it's just lysozyme, then you're looking at paneth, which is a core enterocyte, part of the gut lining. You're looking at a paneth inflammation, and that is indicative of leaky gut. But if you have a lysozyme plus lactoferrin and a lysozyme plus calprotectin, then it's likely irritable bowel disease at that point as well. It could just be that the body's trying to deal with pathogens. So you have to take all of the clinical picture into account. If you have secretory IgA that's low, that could be chronic stress. If you have secretory, that could be low immune function. If you have secretory IgA that's elevated, that can be associated with pathogenicity. So the body is actually trying to fight pathogens. One of the ways I increase secretory IgA if it's low is Saccharomyces boulardii. It's one of the most studied ways of increasing secretory IgA. And that helps increase host defenses. If it's high, then you're going to look at probably using a dysbiosis protocol and restoring proper microbiome, and likely leaky gut protocol as well. Here are your short chain fatty acids, and butyrate being the most important clinically. And your total short chain fatty acid. Again, my cutoff ranges are different. I want a healthy butyrate level for me is above 2.5. If it's lower than that, I may consider more probiotics and or butyrate supplementation for a while. Total short chain fatty acid, my cutoff is 12. Anything less than that, you may consider dosing short chain fatty acids as well. Typically, we see high and low short chain fatty acids in dysbiosis. It's another pathognomonic indicator of some type of dysbiosis. pH is regulated by both the microbiome as well as the digestive acids. So low pH might be not enough pancreatic function or a lot of gram-negative acidic bacteria. High pH might mean low commensal good bacteria, or not enough hydrochloric acid. Beta-glucuronidase is looking at two things. One, gallbladder function, toxin exposure, as well as dysbiosis. Dysbiosis can increase or decrease beta-glucuronidase. And then occult blood, looking at, it could be a colon cancer marker, could be inflammatory marker, those kinds of things. Occult blood always should trigger a follow-up, either another occult blood test, not another whole GI 360, but at least another blood test, and or it might trigger a colonoscopy or a Cologuard or something like that if it's in an individual with family history or over 50, that kind of thing. All right, so these are some of the inflammatory markers as we went over. Okay, you'll have these in your notes. Down here again, lactoferrin and lysozyme can be non-specifically elevated from infection, irritation, even alcohol consumption, but calprotectin is the most specific for irritable bowel disease. Here are my, and what I can do. If you are interested, I have my own interpretation guide, which uses a little bit of my own. Doctor's data can't produce these, but I can as a clinician. So I have a guide, my own clinician's guide to doctor's data GI tests. So if you want that, please email me as well. And that you go to drbrandonlundell.com and I can give you a complete guide, interpretive guide. It's a PDF interpretive guide. So, okay. Intestinal permeability testament, zonulin is an important piece about zonulin. It's a rule-in test, but not a rule-out test. Okay, so if zonulin is elevated, there's almost always active autoimmune, active leaky gut, active breakdown, but it could be short-lived. So if zonulin's high, it's good to treat and then retest to make sure that you've actually treated it. If it's low, it does not mean that the person does not have leaky gut, because leaky gut can exist without zonulin breakdown because the tight junctions have already broken down. So zonulin is elevated usually in the beginning and middle phases of leaky gut, which can last anywhere from weeks to months, but not years typically, unless it's severe, Crohn's or celiac, things like that. Okay. All right, HCl challenge test protocols to assess whether or not someone does have low hydrochloric acid. You can go back and look at the notes here. I don't want to spend too much time on that, but sometimes we do an HCl challenge to see if they are producing enough HCl. Almost always, if someone's on a proton pump inhibitor, it's likely that they have had gastritis, and it's not that they have too much hydrochloric acid, it's that they don't have enough hydrochloric acid. So treat gastritis. And I've got gastritis protocols as well. That you'll have to sign up for my classes. I don't want to give away all of my protocols, but we go deep dive. I spend an entire 15 hours on the gastrointestinal system in my classes. So here's my follow-up testing again. Post antimicrobial, wait at least 21 days to retest. And anytime there's a new symptom, go ahead and do the full GI 360. But if it's stable improvement, routine check, I might only do the CSA or the microbiology. Okay. So a little personal story before we jump into this case study, which I only have a few minutes, but I'll run through the case study pretty quickly. And I have lots of case studies in my classes. So if you want to learn more from me, there's a lot of opportunity there. But my niece got COVID. This was 2021, 2022. My niece got COVID. And triggered pancreatitis, and she was put into the hospital. They didn't treat her pancreatitis. I begged them to use N-acetylcysteine. There's lots of studies that hospitals can use N-acetylcysteine not just for liver failure but for pancreatitis. So she went into respiratory failure. She was put on a respirator, and and they didn't do any natural medicine. They wouldn't look at anything natural, which is very frustrating, as many of you know, in the hospital systems. She ended up developing C. diff, and C. diff is, especially when you get it in the hospital, nosocomial infections can be very deadly, and one of the simplest ways to treat C. diff is with Saccharomyces and with other probiotics, with glutamine, with N-acetylcysteine, and they wouldn't do that either. And she's 26 years old when she was admitted. And unfortunately, she passed away. All of these things built up. All of those could have been treated, and none of them were. She was put on steroids, which weakens the immune system and made the C. diff worse. So it was and I was talking to doctors every day. Just when I was making headway, a new doctor, she would lose that doctor as the case manager, and I'd have to start over. So this lasted for 3 months, and she finally passed away. And I've been passionate about this kind of stuff even before this happened, and now I'm even more passionate about making sure these kinds of tests and evaluations and treatments are made standard of care. So whether that's going to happen in my lifetime or not, I don't know, but I'm on a mission to make sure it does, because we have the evidence to act now. So quick overview of what C. diff is: gram-positive, spore forming, 50,000 infections, 29,000 deaths annually. There's toxin A, toxin B, and then binary toxin. Doctor's data test for toxin A and toxin B, and it's really not there unless there's some kind of C. diff. But you don't always have to treat C. diff. There's a couple of different detection methods. There's the NAATT, which is a basic PCR, or there's an antigen testing, and there's a toxin testing as well. So Doctor's Data does the toxin testing in the parasitology, but if you order the C. diff panel, they will do the PCR and antigen testing as well, and the stool culture. So about 38% of C. diff carriers progress to symptomatic disease, but that means 62% don't. 62% remain carriers. And if it's producing toxin A and toxin B, you still may want to treat it, especially if you retest maybe a month later and it's still there. Then they truly are a carrier. And antibiotic-based eradication is usually not effective. It requires both probiotics and natural antimicrobials, because usually repeated use of antibiotics is one of the causes of C. diff carriers. What it does is it creates a biofilm, and it stays in the system. It might actually, there's lots of studies that I've read that actually shows that it goes up into the biliary tree, and it creates biofilms within the common bile duct, and even in the pancreas or in the biliary tree in the liver. And that's where the toxin actually may be coming from. So in those cases, you want to do systemic treatments. Organic acid markers can also be helpful in confirming C. diff, not as pathognomonic, as definitive as the stool tests, toxin A, toxin B, and culture, but they can give you a clue if it's affecting systemic circulation. And this is really important in preconception, because if the mother has C. diff during pregnancy, being a carrier, these toxins can really affect placental and fetal growth. So it's important to treat, obviously, before they get pregnant. So that's why stool testing is absolutely critical in preconception evaluation. So normal bile acid is important. So not enough bile acid flow is another way that bacteria can go up into the bile duct and into the gallbladder. So we always want to help the bile flow, in any kind of dysbiosis. So, but even after treatment clears, the infection, the microbiota maybe hasn't recovered, bile acid imbalance might persist. The causes of C. diff in the first place need to be treated, and that's why the stool chemistry is so important. So I hope you're all following. I mean, I know I'm going over a lot of information, but you can't just treat the microbiome. You have to treat the environment. You have to treat the causes of the imbalance, which is usually autonomic nervous system imbalance, right? Stress causing imbalance in the secretion of digestive juices. So butyrate is also really important in C. diff as well as Saccharomyces. So butyrate here in this study, Kanashi and Hayes connects this to C. diff. They further show that loss of butyrate producing species during dysbiosis is a key driver of creating an environment within which C. diff can both be toxigenic as well as be a carrier. So, and that never gets treated when someone takes an antibiotic. And my niece was on IV antibiotics for months, and it's part of what killed her. So it's this dual vulnerability that needs to be treated when you are looking at C. diff, both symptomatic and asymptomatic. So, and this is just how probiotics, together with antibiotics, if this was standard of care, it would actually reduce about 80% of recurrent infections, according to these studies. So pretty amazing. So here's what, but just a summary of what we use in functional medicine to treat C. diff, whether they're symptomatic or asymptomatic. But remember, the symptomatic needs to be asymptomatic. You need to look at the full clinical picture to decide whether you're going to treat. Okay. So never interpret the dysbiosis index in isolation. Doctor's data uses 4 microbiology categories: the expected, imbalanced, dysbiotic, and pathogenic. So you want to look at all 4 of those. It uses PCR, parasitology. Use your progressive testing map. Don't just do the GA360 on everybody all the time. And treat the entire gut-brain axis. Don't just treat the microbiome. All right, so here's a case study. We'll go through this pretty fast. It's I know we're about 5 minutes over, so you guys it's well worth sticking around for another 5 minutes. And as Lylan said too, this will be recorded, so you can go back and listen to this. But this is a 23-year-old female with systemic and neurological inflammation. Her name is May. Presenting complaints: severe depression, anxiety, ADHD, weight gain, fatigue, sweating all the time, nausea, bloating, even intermittent vomiting, irregular periods, severe PMDD, chronic pain, low back, neck, shoulders, unable to hold a job or attend school. And she's very smart. This easily could have been the end of her life, not literally, but figuratively. She was on polypharmacy: Prozac, Wellbutrin, Remeron for sleep, Vyvanse for ADHD, diclofenac and gabapentin for pain, which provided very little relief in the first place, and they just kept upping her dose, which is bad medicine at the very least, if not downright, malpractice. She had a hormonal IUD. She tried ketamine, which provides some short-term relief, but never long-term. These things like ketamine and, peptides, these are all wonderful treatments. Even psilocybin, these are all wonderful treatments. But if you're not treating the gut and you're not treating the core imbalances, none of them are going to last. Does this make sense to everybody? I really hope this makes sense, because there's a lot of people in the functional medicine realm that are doing all of these, cool things, and ketamine and psilocybin and MDMA and peptides, but they're not treating these underlying imbalances. And guess what? Ketamine doesn't treat this. Psilocybin doesn't treat this. MDMA doesn't treat any of this. And so they usually, in the literature, supports this. They get short-term relief, and they have to do it again, right? When we look at standard of care for ketamine, they're having to do it every 6 months. And then every 3 months, and then every month, because the more you do it, the less effective it becomes. Relevant history, don't need. I'm not going to go deep into this case today. I want to just go into how we kind of evaluate it. This is her symptoms, excessive worry, diminished motivation, aches and pains, night sweats, decreased libido, burned out feeling. I mean, she had a lot of these things. So we run blood work on everyone, and she wasn't that metabolically, insulin resistant. So that's good. Doesn't mean that, her diet was great by any means. It wasn't. And this kind of got out of balance, but she had low vitamin D because she wasn't able to absorb. She wasn't on vitamin D. She wasn't able to absorb it, even if she was. And high cholesterol and triglycerides in a 23-year-old usually means gallbladder dysfunction. So does vitamin D, especially if they're taking vitamin D and they're still low. That is almost pathognomonic for gallbladder dysfunction as well, because it's a fat soluble vitamin. And if you're taking 5,000 IUs, 10,000 IUs, and you're still at 20 or 30 or even 40, you likely have gallbladder insufficiency. Her CRP was very high at 3.7. Her thyroglobulin antibody was high. So while her thyroid levels were still maintaining, this was a precursor to thyroiditis or thyroid problems. So she has autoimmune. You don't get thyroglobulin antibody without having an autoimmune imbalance. Her urinalysis also showed white blood cell esterases, which is inflammation. Oh, there's my cat. She wants to chime in. And she had Epstein-Barr. This is, I can go into Epstein-Barr treatment, but these titers are relatively high. So while it means that she definitely had a past infection, these levels of titer usually means that it's also pretty active in the body. So you want to look at antivirals. We do IgG food sensitivity testing because it helps with evaluation of leaky gut and foods that contribute to leaky gut. So dairy and gluten were very high. Even beef and eggs were very high. So we removed those. And sure enough, she had positive IgG antibodies to Candida, which doesn't necessarily mean that she's got an active Candida infection, but it does indicate two things. One, that she might have an active infection. She's likely to. And that if she does, she's likely it's more likely to cause problems because she's developing antibodies to them. So it's likely going to be more inflammatory. So we ran some organic acids and we see while she was eating enough protein, she wasn't absorbing and breaking down her proteins into amino acids. So that's another indicator of hydrochloric acid insufficiency. So her digestive system already, we have clues that it's not functioning well. And we can see almost all of her neurotransmitters being low because of the protein insufficiency, even though she was eating enough protein. So this is where organic acids can be very helpful. Her homocysteine was elevated, 11.3, so a methylation issue. Some of her nutrients were okay, but these are just population-based averages, doesn't mean that she's actually getting enough. So you have to look at some functional tests. Some of her vitamin E was low, beta carotene's low, so that means her diet didn't have enough vegetables. She wasn't eating the rainbow. She wasn't eating enough, beta carotene foods. And that gets converted to vitamin A. Her glutathione levels, when someone's in an active disease state, we want these glutathione levels to be as high as possible. Her peroxides, her oxidative stress was pretty high, and another confirmatory test that her vitamin D was low. Her essential fatty acids were imbalanced, so on and on. We can go. Her beta hydroxybutyrate was high, which is actually a more sensitive indicator of insulin resistance than hemoglobin A1C and fasting blood sugar. All of her energy metabolites were elevated, meaning that she was not able, her mitochondria was dysfunctional, pretty severely dysfunctional. I rarely see all of these in the upper quintile. So she had no mitochondrial function, very little mitochondrial function. So you can see why these things don't get addressed when you're just doing peptides. And by the way, I've got a seminar that I'm doing all day on March 28th. And I'll go more into this case study and others, how do we do, if we are going to do psilocybin, if we are going to do peptides, how do we make those things work? If we're going to do stem cells or PRP, what can we do to make sure that that actually works and it saves the patient money because they don't have to do repeated round after repeated round? And this is the kind of clinical evaluation and treatment that is absolutely necessary in functional medicine. And it's how I treat almost all of my patients. Benzoate is high, which gives you a clue that their GI test is likely imbalanced. And sure enough, this is her actual GI test. She had a great imbalance in her firmicutes and proteobacteria, low short chain fatty acids. Okay, these are the actual subclasses in your phyla. So high allostipes and parabacteroidetes. She had low Akkermansia, which, as you know, is just an indicator of dysbiosis. You don't have to give someone Akkermansia, but it also predicts severity of disease. So whether Akkermansia is high or low, that can be an indicator of needing treatment right away. And then no protozoa, no tapeworms, no roundworms. This is all on the GI 360 page by page. She didn't have any pathogenic bacteria, but she did have Klebsiella. Even though it was a 1+ growth, that doesn't mean that you don't treat it, right? She had dysbiosis. It could have just been that sample that was a 1+ growth. Doesn't mean you should automatically treat it either. You have to evaluate the whole clinical picture. Staph and strep is often there, but a 2+, 3+ growth indicates dysbiosis. She also had a 2+ growth of Candida. So she was, I think the clinical term is a hot mess, right? So there's an ICD-10 code for that, I'm sure. We did the Candida albicans sensitivity, so we knew that grapefruit seed extract. This was a couple years ago before they changed, but grapefruit seed extract had high affinity uva ursi and caprylic acid. So we have our treatment plan right there. We could do nystatin if we wanted to, but I typically don't. I like to use natural first. This is our stool chemistries. Nothing too bad except the low short chain fatty acids. Lysozyme was a little bit elevated. My cutoff is 250 or 300, and she was 449. So yeah, some inflammation and leaky gut. Remember, lysozyme is an indicator of leaky gut. And I have my own ranges, as I said, so you can email me through my website, and I can give you my own ranges. A lot of them are the same, but some of them are different. So that's what we see. We looked at short chain fatty acids. We already talked about this, why it matters, what we do with it, and we gave her some short chain fatty acids to help balance her microbiome and to help heal the leaky gut. Someone will never heal leaky gut unless they have enough short chain fatty acids. I'll say that again. They'll never heal leaky gut unless they have enough short chain fatty acids. It's a necessary, but not sufficient. Meaning, if they do have enough short chain fatty acids, doesn't mean they're going to heal leaky gut, but they'll never heal leaky gut with low short chain fatty acids. So this is just a schematic of what the acetate, propionate, and butyrate do. We have all the receptors in our enterocytes, colonocytes. It increases GLP-1, GABA, 5-HTP. One of the things that we use in place of GLP-1 agonists in clinical practice. And this is, this, but I'm going to tell you, GLP-1 agonists cause leaky gut. There's studies are very definitive that GLP-1 agonists like Ozempic cause leaky gut. That's pretty much known now, but if you didn't know it, now you do. So it's actually making the microbiome and metabolome much worse, which is usually what drove and drives the weight gain in the first place. So as a typical drug does, it never treats the underlying issue. It's only a short-term fix that comes at a very high cost. So she also had a vaginosis panel because she had vaginosis symptoms. She went through a regular doctor and it was negative. Okay, now it did have candida, but I decided to do the doctor's data because the doctor's data also has a vaginosis panel that's much more sensitive. And sure enough, she also did have Gardnerella, and she had these other imbalanced flora too. So we put her on a vaginal dysbiosis protocol as well, which again, these are things that I can give you if you take my courses. Okay. I'll give out a few of these, but not all of them. We also addressed her hypothalamus, pituitary, and adrenal axis dysregulation, high HPA imbalance in the morning, and then adrenal failure throughout the rest of the day, causing hormonal imbalances, low testosterone, low progesterone, and those kinds of things, low DHEA. We did neurotransmitter testing as well. This is beyond the scope of this class, but I find great utility in neurotransmitter testing. I gave a great functional neurology webinar for Doctors Data, and you can go to their menu of webinars, and many of them are recorded, and they're for your. It's such a great library. Myself and many other brilliant doctors are on there. Another clinical pearl that I'll almost end with here is taurine. One of the things that I use, she was very low in taurine. Taurine is not only necessary as a neurotransmitter, and supports dopamine and serotonin levels, but it also is one of the most important mitochondrial protecting and biogenesis spurring amino acid and component, even more so than CoQ10. It's almost to the point where I don't give CoQ10 without taurine. So I'm not going to go too much into taurine, but you'll have it in your notes. Increases BDNF, modulates GABA. She was already on gabapentin, which we can usually get people off of GABA, doing a lot of taurine, doing a lot of kava, doing a lot of sometimes we use St. John's wort and mucuna, but taurine is one of my favorite, and kava is one of my favorite to help people get off of pain medications. Taurine is neuroprotective. It reduces diabetes. So just one of my favorite things. And due to time, I'm going to skip through some of these, but taurine is just it increases acquisition and retention in the brain. So pretty amazing at what it can do. So here's just some dosing. You do have to use therapeutic doses, 500 to 2,000, even 3,000, even 4,000 milligrams a day. But I typically start with 2 to 3 grams a day. So make the correct diagnosis first, right? That's functional medicine. Don't just treat it with ketamine. Don't just treat it with an SSRI. Don't just treat it with those kinds of things. Don't just treat it with a probiotic or a methylfolate either. Actually look at the diagnosis: systemic inflammation, dysbiosis, high viral load, mitochondrial dysfunction, autonomic nervous system imbalance, methylation abnormalities, and of course the nutritional deficiencies induced by polypharmacy. This is what functional medicine doctors treat. A good doctor knows what to do. A great doctor knows why. This is the why. Okay. So we use what I call the three-legged stool. We use diet, exercise, mindfulness, breathing, even chiropractic, laser, hyperbaric, cold plunge. I use a lot of hyperbaric in my office. We do some IVs sometimes, and of course, supplementation. This is what supplements we started her on. I know it seems like a lot, but we have the evidence that she needs all of these things. And this is how we treat. I think a lot of practitioners are afraid to use enough nutraceuticals in the doses that are necessary to induce a response, and they have a lot of treatment failures. And it gives functional medicine a bad name. I don't think giving a lot of supplements gives functional medicine a bad name as much as not giving enough at the doses necessary, because it's ineffective. It ultimately wastes money, wastes time, and we lose another patient because they tried functional medicine and said, well, I spent $10,000 and it didn't work. That is what we have to eliminate. I'd rather a patient say, I spent $20,000 and I'm a completely different person and it worked, than I spent $10,000 and it didn't work. Okay. So after 4 months, she lost 20 pounds. She wasn't sweating. She started to exercise for the first time in years. She felt normal for actually a couple hours every day. No more going to the hospital. She did have trouble swallowing all the pills, and I have many strategies on that I go into. We can back it off. We can, we can start slow. She was off Remeron, gabapentin, half dose of Wellbutrin. I guess she started a half dose of Remeron, but at 4 months she was off Remeron, and she started to wean off of her Vyvanse, which is very tough to wean off, as you know, those of you who have helped patients do that. After 6 months, she lost 40 pounds. She got a full-time job. She did ketamine one more time, but this time it actually stuck. Geez, I wonder why. Because it's a wonderful therapy to reset if needed, but it never lasts unless the brain is able to actually change permanently. She does do hyperbaric oxygen once a week to kind of get a boost, and she does IVs once per month, and she did that for another 6 months, and now she's pretty much on her own. She doesn't do any of this, and we saw after 6 months no more dysbiotic flora. She did have low lactobacillus and bifidobacter, so we did increase her probiotics. And the last thing I want to say about the doctor's data test is this is the bacteriology culture that is in the comprehensive stool analysis. Just because this is green, this is really important. Just because this is green does not mean everything there is where it should be. This is where, I think it could be reported differently, and they're actually, doctor's data is starting to report it differently, so it makes sense. If it's a 1+, then it actually means that's not enough growth of the expected beneficial flora. So it really should be in the green, but with a highlight that says it's still imbalanced. Okay, so we know that even though she's not as dysbiotic anymore, which is great, she still doesn't have enough good bacteria. So, but after 6 months, sometimes it takes a year or more to truly repair the gut dysbiosis and leaky gut. No more candida, or she did have candida, but it's down to a 1+. And so we continue to help it get better and better. Like I said, it can take a year or more. So that's the case study. I'm sorry I went over again. I thought I could do this in maybe 70 minutes, but we're at 84 minutes. So you guys are awesome. If you're ready to learn more, to take your practice to, being able to do this with all of your patients and being able to do it with confidence, I do mentorships. So you don't even have to take any more training. What I help you do is incorporate the training that you've already had, whether it's IFM or FMU or, whatever training you've had. We do a 6-month mentorship intensive where we meet with a small group once every other week. We do one-on-one every month. And I give guidance with labs. I do give you homework. I assess where you are, where your trouble is, what you're having trouble incorporating. And we develop a plan so that in 6 months, I have a 90% success rate in taking people through the program, and they are dramatically different and confident at the end of that 6 months. So I have a cohort that's starting in April. So this is a perfect time to sign up. I've only got about 5 spots left because I do so many one-on-ones and I only have so much time that I only allow about 14 people through, 16 people through, and we have about 5 spots left. So sign up now. You can go to my website. It is $6.99 a month, which is probably the least expensive mentorship training out there. And you can save a whole month by paying all at once if you want to. And like I said, it's, these are people who have taken it multiple times. A lot of people get so much out of it, they take it again. I've got some people that have taken it 3 or 4 times. So again, I've got one coming up on April 9th. It's sponsored by Biotics Research, Doctor's Data. You get free products, you get free tests. You get about $1,500 just when you sign up in free tests and products just out of the gate. So that pays for almost half of it right there. You're nothing like this exists. And I've got people that come in. I've got other practitioners and that you can learn from. So it's a wonderful opportunity, and it's where I really love putting my time and energy. And like I said, I'm giving a 1-day lecture, March 28th. We'll talk about AI, fertility, cardiometabolic health. We'll go through case studies, how to use peptides, environmental medicine, all of that in just 8 hours for the very affordable price of $199. And so I hope to see everybody there. Thank you so much, Doctor's Data. You guys are awesome. Thank you for letting me do this periodically, and we'll open it up to questions if Lylan, you're willing to stay for a couple more minutes.